Yes. Good morning, friends. Can you hear me?
Yes.
Good morning, friends. Welcome back to Saturday Club morning meeting. And today we have a very, very eminent cardiologist from USA to talk to us about cardiac defibrillation, historical perspectives, and review of current practice. He is Dr. Ravi Shah. He has done his MD and MBA. He's a cardiologist and electrophysiologist in USA. His CV is in fact very interesting. I can't read through whole of the CV. It's a one-page CV, but to briefly summarize his resume, he is a board certified in cardiology, echocardiography, internal medicine, and general pediatrics also. He has a great passion for innovation in diagnostic and management technology, care delivery, and healthcare policy. He was past VP strategy at 2 Minutes Medicine Incorporated, past chair Health Policy and Fellowship Initiative. He's a team lead and director of business development at Simplify, and he's recipient of AMA Foundation Leadership Award. This is very brief. During his course of talk, I would like Ravi also to tell us something about his multifaceted career that I have been able to read through his CV. So over to Dr. Ravi. You have about 45 to 50 minutes to talk, and we'll have about 10 minutes of discussions. Over to you.
Thank you so much. That's very kind of you. And thank you everyone for having me today. It's an honor to present to you all. I will try to talk a bit about cardiac defibrillation, and we'll try to not get into too many details. We'll try to focus on the overarching themes. That's somewhat difficult. So right now, I'm studying cardiac electrophysiology. I've completed my fellowship in general cardiology, and that included training in echocardiography. I always found the spectrum of disease and how people evolve, how society evolves very interesting. And so that led me initially to pursue pediatrics and internal medicine. So we don't have too much time, and we have a lot to cover. And so we'll get started. If at any point you have any questions, feel free to interrupt. It will not be a problem. So we will start with the case, as we typically do. So we had a patient of ours who came in. He's 55 years old. He has history of a non-ischemic cardiomyopathy. His ejection fraction was about 20%. He's not great at follow-up, but we know that he had a Boston Scientific CRT-D device that was placed. His past medical history included hypertension, hyperlipidemia. He's a current tobacco user, and other substance abuse as well, unfortunately. So he was at his son's baseball game, which is similar to cricket, but Americanized, when he lost consciousness for 1 to 2 minutes. And he wasn't really sure what would have happened, but EMS was called. So this is our 911 service. The ambulance came and they brought him to the hospital. When we interrogated his device, we saw that he was having episodes of ventricular fibrillation. And he was treated initially with what's called ATP, which we'll talk about, but he received 6 total shocks from his device. Typically, we hope to see that only a single shock will resolve the arrhythmia, but he needed 6. And when he was in the arrhythmia, his ventricular rate was almost 300 beats per minute. And this lasted for 1 minute and 45 seconds. And so when we did his device interrogation, this is what we see. This is an interrogation of the ICD. And so what we're looking at here, this is the ventricular sensing channel. On top is the atrial sensing channel. And we'll go through this as well. And the bottom is the shock vector. But what you're seeing is these very, kind of a very fine rhythm, which represents ventricular fibrillation, not even ventricular tachycardia. This represents very disorganized activity. There's effectively no contraction of the ventricles. And I'm showing you the very tail end of the shock sequence. This is his sixth shock that he received right here, which ultimately resolved the fibrillation event. So this is concerning, being electrophysiologists, we are hoping that we have a device implanted in the patient that would resolve their arrhythmia after a single shock. And so we brought him back toward the lab to do something called defibrillation threshold testing, also known as DFTs. And so we sedated the patient and we induced ventricular tachycardia, and his device appropriately delivered the shocks, but they were unsuccessful. And so to a point where he had to be externally defibrillated, and he did awake without any issues. As part of his workup, and part of anybody's workup who comes in with a shock, we look at the device. So this was his device. This is a dual chamber device that he has. And you'll see a coil down here. There's also a coil up here. It's not very clear on this picture. And then he has an atrial lead. And again, this is not very clear, but we'll talk about this more. Just so we're all on the same page, a quick recap about what ventricular tachycardia and what ventricular fibrillation actually are. VT, ventricular tachycardia, represents an organized rhythm, but it's driven by the ventricles. And if you look at it on an ECG, it'll be wide complex. At faster rates, it'll be life-threatening, but it does represent a non-physiologic activation of the ventricles. So this is an impulse that's beginning lower down in the heart and then activating the rest of the myocardium. Ventricular fibrillation, however, represents disorganized ventricular activity with no effective contractions. So if you have a ventricular tachycardia that's going at a reasonably slow rate, you will survive. And you'll be meditating, you can even talk. I have a patient right now who I saw in the ED who had VT at a rate of 105 beats per minute. It's difficult to manage, but he was awake, he's alert, he's able to communicate. He just did not feel well. With ventricular fibrillation, there's no cardiac output, and it will imminently lead to sudden cardiac death. We should very much honor the people who have developed the technology behind defibrillation, because it's our tool against sudden cardiac death. So where did this really start? In the 19th century, there was a Batelli and Prevost. They saw that a weak current could cause ventricular fibrillation. But if you had a stronger current, it could actually stop ventricular fibrillation. And this was a key finding. And so Hooker and Quine-Hoven in 1932, they proved that you could do defibrillation externally. And then by the 1940s, Guvich and Yunev had proved that shocks from capacitors could defibrillate dogs. And this was a key experiment. In 1956, Paul Zoll developed the first AC defibrillator. In 1960, the first DC defibrillator was invented. And then what we use currently, which is biphasic defibrillation, was invented in the 1980s. There's a lot of history in the middle of this, but I had to fit it into just a short slide. We're talking today about the implantable Cardioverter defibrillator, also known as the ICD. So Dr. Mirkowski, developed the first implantable ICD in 1980. The first devices were very large, almost 280 grams in weight and quite large in size. You needed to have open chest surgery, and the device was implanted in the abdomen. Dr. Mirkowski was actually inspired by the death of his colleague, almost a decade earlier, who had died from VT. So he wanted to come up with something that could save people's lives. And so early on, it was very common to have complications. The computer technology had not yet caught up. And so there were very limited algorithms. Initially, it was developed for secondary prevention. And even that, people thought, there's no way this is possible. Ultimately, with research, and we'll talk about all these trials, primary prevention came into play. And we saw that for primary prevention and for secondary prevention, we're seeing up to a 30% reduction in mortality. Looking at an ICD, this is a very basic schematic of it. You have your generator and your capacitor. You have a header here made of acrylic. You have leads that come out from the device, and they snake down to the heart here, right? So this is in the atrium, and the bottom one is in the ventricle. What you're looking at right now is a schematic of a dual coil lead, and we'll talk about that as well. I always find that it's very helpful to always understand what you're looking at when you look at an X-ray. And so if you see a patient in an emergent setting and all you have is an X-ray, you can still tell what kind of device they have. And that's going to provide you with a lot of information about what you can do next. What are your next diagnostic steps? So if you see a patient like this, well, you see a generator, but you see only one lead. And the first question you have to ask is, where is that lead going? So if it's going to the atrium, it's only going to be a pacing lead. If it's going to the ventricle, it can be an ICD lead or it can be a pacing lead. And so what you're seeing here is that the lead is curling up in the right atrium and it's anchored at the superior part of the atrium here. Here, what you're seeing is a dual chamber pacemaker, right? So there's an atrial lead here and there's a ventricular lead. And these are both pacing leads. This does not represent an ICD. Also interesting about this is that the device is on the right side. Most commonly, we place devices on the left side, unless patients are left-handed, in which case we prefer to place it on the right side to decrease friction on the leads, to decrease chances of lead failure, and to overall preserve the longevity of the device. Sometimes what you'll see is a device with 3 wires. And so what we talked about before, there's a wire going to the right atrium, right here. There's a lead going to the right ventricle. And what you're seeing here is this thicker lead, right? This represents the shock coil. And that's imperative to the defibrillator function. And the third wire you're seeing, it looks like it's at the same level as the ICD lead, but it's actually curving around the back of the heart. And that's in the coronary sinus. This is a coronary sinus lead for something called CRT, cardiac resynchronization therapy. Now, I know you had a presentation just a couple of weeks ago on pacemakers that covered CRT, so I won't talk about that too much. When we look at the device interrogations, this is just a schematic of what we see. And so, again, you have your generator and 1 or 2 coils. It's standard of practice now to only implant single coil devices. And so what we see is a CAN to RV coil, so a vector from the coil to the CAN, and then from the tip to the CAN, which represents the pacing vector. And then what you'll see on the bottom or the top is how the device is characterizing the signals that it sees. So to come back to sudden cardiac death, just to provide some perspective, sudden cardiac death still remains a major challenge, despite all the advances we have in managing coronary disease, managing heart failure, managing arrhythmias. No matter how many ablations we do, no matter how many devices we put in, figuring out how to manage sudden cardiac death is still a challenge. And pharmacologic management is difficult because you really only have 2 drugs that can help. Those would be your amiodarone and maybe sotalol for secondary prevention. But device therapy still plays a fundamental role for all those times that you can't predict what's going to happen. So I want to take a quick pause here. Does anybody have any questions? Okay. So let's move on to the evidence that we have. Why do we implant these devices? There are a lot of words on this slide. I'm just going to provide a quick overview. Some of the main trials were the AVID trial, the SIDS trial. This is for secondary prevention, meaning that the patient has already suffered an episode of ventricular tachycardia or sudden cardiac death. And what we found is in patients who have ICDs implanted for sudden cardiac death, as compared to amiodarone, there was a 16% reduction in mortality if the patient had an ICD implanted. And in comparison to amiodarone, patients with ICDs had a 39% reduction in mortality at 1 year, 27% at 2 years, and 31% at 3 years. Even more interesting is the risk of arrhythmic death. So the risk of death from an irregular heart rhythm was reduced by 56%. To follow up these findings, there was another trial done called the SIDS trial. And this enrolled patients who had a prior cardiac arrest, who had history of unstable VT, or had sustained VT greater than 150 beats per minute that was symptomatic, or had angina with an EF of less than 35%. In those patients, we found that their mortality was reduced by 20%, and the risk of arrhythmic death was reduced by 33%. There was a few other trials done, but a meta-analysis did show that ICD therapy reduced mortality by 23% compared to pharmacologic therapy, and the risk of arrhythmic death was decreased by 58%. But the interesting finding of this meta-analysis was that there was no benefit to ICD therapy in patients with an EF greater than 35%. So when we talk about primary prevention, how do we know which patients to include in that cohort? Early on once we were able to understand LV dysfunction, we found that low EF, so low ejection fraction, was the most powerful predictor of mortality and sudden cardiac death. And so in patients who had a ejection fraction less than 30%, you have a 20% mortality risk at 2 years. That's without any therapy. So there was a major trial called the MADIT trial for primary prevention. And in those patients who had an EF less than 35% or had documented VT during an EP study, they had a 54% reduction in mortality if they had an ICD implanted. And there was the MUST trial, which also showed a 24% reduction in mortality with an ICD implanted. Two other big trials were the MADIT-2 trial and the SCUD-HEF trial. These are often quoted in the literature, but all showing very consistent results. This is a graphic from the main textbook on devices by Ellen Bogan. And what it's showing is that, in all these trials, there are very consistent results. ICD therapy was reducing mortality between 20 and 30% in all three of these major trials. This is a composite chart, and I've highlighted the hazard ratios for total mortality in these populations. The bottom three trials show a different hazard ratio, but it's interpreted differently in the context of that trial. We don't have time for that today, but what we're seeing here again is very consistent results for secondary prevention and for primary prevention, that your hazard ratio for mortality is significantly reduced with having an ICD implanted versus just medical therapy. And so that brings us to guidelines and recommendations. We will talk about that more on the next slide, but in secondary prevention, if you survive the cardiac arrest due to a VT or VF, or if you've had hemodynamically unstable VT or stable sustained VT, it's not due to a reversible cause, it's a class 1 indication to have an ICD implanted. If you have unexplained syncope in somebody who has ischemic cardiomyopathy with inducible sustained VT on an EP study, also a class 1 indication. Class 2 indication for patients who have a non-ischemic cardiomyopathy, but who have had ventricular arrhythmias. The corollary to this is there are a lot of subsets of patients with either hypertrophic cardiomyopathy, who have some of the genetic channelopathies, where these recommendations don't necessarily apply. But again, it's outside the scope of this talk, and we're just going to focus on the fundamentals here. In primary prevention, if you have an LVEF less than 35% and class 2 or 3 heart failure, it's a class 1 recommendation to have an ICD implanted. Even if you have class 1 heart failure, if your LVEF is less than 30%, it's still a class 1 recommendation. If you have an ischemic cardiomyopathy with non-sustained VT and an LVEF less than 40%, and you have inducible VT or VF, then you should have an ICD implanted. So this is an algorithm, basically a schematic about who should get a device. And what this should show you is that it's not always straightforward. You can follow an algorithm, but our patients seldom fall within very defined categories. If someone has coronary artery disease, this becomes a lot easier. With the non-ischemics, with the channelopathies, it's more complicated. The other big thing is, where do you draw the line for the LVEF? We know that even at an LVEF of 40%, your myocardium is not normal, and you still may have scar, and you're still at risk for having sudden cardiac death. It's just not to a degree where an ICD would be proven beneficial. The other thing is, LVEF measurement largely relies on echocardiography, and echocardiography is generally accurate, but it also depends on who the reader is and who the sonographer is for accuracy. So at least here, we go by the AHA HRS guidelines. We have to, and these were last published in 2017. Generally speaking, you have guideline revisions about every 6 years. So I would imagine this year or next year, we should have new guidelines on arrhythmia management. So what do these guidelines cover? All recommendations relating to ICDs require a meaningful survival of more than 1 year. That means you have a reasonable quality of life and reasonable functional status. You would not implant an ICD in somebody who you thought had a survival of less than 1 year. These guidelines specifically talk about sudden cardiac arrest and sudden cardiac death relating to tachyarrhythmias, not bradyarrhythmias, or pulmonary embolism or aortic dissection or anything like that. And these are aimed at the adult population, not meant for pediatrics. What's interesting is that these guidelines also talked about value, right? And so what's a high value recommendation? What's a low value recommendation? They've figured that if your quality adjusted life years gained for the procedure was costing less than $50,000, and this is high value. If it was more than $150,000, it was low value. And we won't go through all of these, but something important here. If you have a patient who has incessant VT or VF, until that is not controlled, you don't want to implant an ICD. A significant cause of morbidity, not mortality, but morbidity in these patients is repeated ICD shocks. Many of these patients who are getting shocked numerous times will have PTSD, or who have device malfunction and they're getting shocked unnecessarily will have PTSD. And they become very averse to having the device. Some patients even want it removed just because they're getting shocked. So you want to have good control. The other thing is, in somebody with ischemic heart disease who has sustained monomorphic VT, coronary revascularization alone is ineffective to prevent recurrent VT. So you're going to need an adjunctive therapy, an ablation, an antiarrhythmic, and likely a device. So in secondary prevention, in patients with ischemic heart disease, the HRS and ACC gave this value an intermediate value. This is in secondary prevention. In primary prevention, interestingly, it's a high value, because they figured for the amount of money that you would spend in to try to increase the quality of life, to prolong this person's life, it far outweighs the cost that they would have in the patient having an event, potentially dying, being admitted to the hospital, so on and so forth. Again, to highlight, you should not implant an ICD in somebody who's NYHA class 4, who has medication refractory heart failure, and who's not a candidate for other advanced therapies, like cardiac transplantation, LVAD, which is an assist device, or CRT. So we should talk about the physiology of defibrillation, right? Everything we do should have a scientific basis. It's not just delivering a shock. This has been studied. And so what are we trying to do? We're trying to deliver a shock that's going to alter the transmembrane potential enough to halt the fibrillation wavefronts. And so what we're trying to do is to get a critical mass of the myocardium at simultaneous depolarization. So the membrane potentials of all the myocardium, or as much as we can, should be at a similar value. And so of the sites that are viable in the heart, we want them to resume normal conduction after the shock. Over time, we found that biphasic shocks are more effective than monophasic shocks. And this has to do a little bit with the mechanism of VF, and there are different hypotheses that can go into that. There's one called the motor rotor hypothesis. There's a multiple wavelet hypothesis, but basically saying that it's a self-perpetuating process. And so we're trying to break that. This was a very interesting experiment that was done by a group by FMOV. And so what they found was in a monophasic shock, when you depolarize the myocardium, you end up actually creating a potential here. There's a gradient between these different portions of the myocardium. Then they tested out something different, a biphasic shock, where you depolarize to a certain extent and then repolarize the other way by either half or double the voltage. And what you're getting is a much more homogeneous transmembrane potential of the myocardium. And we found that to be much, much more effective. Other than defibrillation, we have one other technique that we can use to stop ventricular tachycardia, and that's called anti-tachycardia pacing. It's also known as high rate overdrive pacing. And it's been shown in multiple trials, multiple experiments, that this is effective at terminating the ventricular tachycardia. And we do this by pacing the ventricles at a slightly faster rate than the tachycardia. And by doing that, we enter the circuit of the tachycardia, but the part of the circuit that we depolarize then becomes refractory. And so the circuit cannot continue. There is a risk here of accelerating the tachycardia or having the tachycardia degenerate into ventricular fibrillation. And for this reason, you cannot perform ATP with a pacemaker. You can only do ATP if you have a cardiac defibrillator. And so when you look at kind of a schematic of how this occurs, what you're seeing here is two types of ATP. One is called burst pacing and one is called ramp pacing. In burst pacing, there's a stable cycle length, so stable amount of time between the pacing stimuli. In ramp pacing, the cycle length or the amount of time between the pacing stimuli decreases. This might be hard to see on your screen, but what we're looking at here is an example of ATP. And so this person is in a ventricular tachycardia. It's going pretty fast here. It's characterized into the VF zone because of how fast it's going. And then right here, you see that the device is pacing the heart. And it's pacing the heart slightly faster than the rate of the ventricular tachycardia. And it's successful, and it causes the VT to break. The patient is in atrial fibrillation. That's what this top line is. But the ventricular irregular rhythm is no longer there. And then we talk about, okay, so if we can't do ATP, what determines the threshold at which we can achieve successful defibrillation? And that was the point of this case initially. There's a minimum amount of energy that's required to reliably defibrillate the heart. So we want to know that, as many circumstances as possible, this amount of energy will lead to successful defibrillation. And there's a probability of success curve that is affected by a lot of different factors. We do DFT testing only rarely now. It used to be standard practice 10, 15 years ago. If you were to implant a ICD, you would almost always do DFT testing. The way it would work is we would induce the tachycardia and then allow the ICD to detect it and to terminate the arrhythmia. And there are a lot of different factors that you can adjust. You can adjust the voltage, tilt, which has to do with the current, the polarity, and the duration of the shock. But again, that goes beyond the scope of this talk. We have different strategies about how to determine what this threshold was. And so again, historically, it used to be the standard of care. But between 2010 and 2015, there was a significant decline, at least in the United States, to do DFT testing. And almost half as many providers did it in 2015 than in 2010. At this point, I would estimate that it's even less than that. There's been a cultural shift, but then there are high-use centers that are more likely to perform, and it is dependent on provider to provider. What we found is that there are such improvements in technology. The current generation ICDs have about a 90% success rate. And so it doesn't seem right to subject the patient to unnecessary shock. They have not found any differences in all-cause mortality and the composite outcome of ICD efficacy between performing DFT testing and not performing it. But the number of DFT testing events that you have to do to prevent one death is over 500. Even though you have a significant risk if you do perform DFTs. There are certain classes of patients we want to do DFTs in, and this is a scoring regimen that you could do to figure out who would fall into a high-risk category. There were 2015 recommendations about performing DFTs and who should have it. The class 1 recommendation, though, is for somebody who has a subcutaneous ICD. They should always have DFT testing. So whenever we place a subcutaneous ICD, we always do DFT testing. We will sedate the patient. We will do basically RNT, cause VT or VF, and allow the device to detect the arrhythmia and then deliver the shock to prove to ourselves that this will actually work for the patient. In some cases, it's reasonable to perform it if they have a right-sided device because the vector of the defibrillation is different than we would typically have. It is a contraindication to perform defibrillation testing in somebody who has a cardiac thrombus, who has atrial fibrillation or atrial flutter without systemic anticoagulation, because that risk of thromboembolism still exists. Patients who have critical aortic stenosis, unstable coronary artery disease, who've had a recent stroke or TIA, who are hemodynamically unstable, they should not have DFT testing done. How do we define a high defibrillation threshold? If you need more than 25 joules as an absolute value to abort or to defibrillate, it's a high DFT, or if the safety margin is less than 10 joules below the maximum device output. Reportedly, this occurs in between 2 and 24% of patients, but it's hard to pin down a number. What influences that defibrillation threshold? So cardiac pathology. Do they have ischemic disease? Do they have non-ischemic disease? Do they have an infiltrative disease? All of these things matter. How long has the patient been in VF? The longer you're in VF, the more difficult it will be to defibrillate you. Also because you're becoming acidotic, you're hypoxic, it's going to be very difficult to get you back to a normal rhythm. Anthropometric. So, what's the patient's size? What's the position of the ICD? All that matters. What drugs they're taking. And altered shock pathways. So this was a schematic that was put together by the or in an article in the Indian Pacing Journal, and it's very nicely done. But it shows how complex it actually is to figure out what the DFT is, and how many things you need to think about if a patient is not having an appropriate threshold. There are pharmacologic factors as well. And so this is mediated by ion channels, electrolyte concentrations, there's intravascular volume and neurohormonal modulation as well. Sodium channel inhibition matters as well, depending on what drugs they're taking, and potassium channel inhibition. And so grossly speaking, if someone's on amiodarone, lidocaine, mexiletine, you may find that their DFTs are increased. But if they're on sotalol or beta blockers, you might find that they're decreased. But you'll also find for amiodarone, like most things are for amiodarone, there's conflicting evidence about the efficacy. And so non-invasive management, right? Fix their metabolic derangements, change their medications, optimize their heart failure. If they're volume overloaded, let's figure out a way to diurese them. And then you want to optimize the shock. The electrophysiologist will be the one who's most likely working with optimizing the shock vector. But if you do see them in clinic, or if you see them in the hospital, it's important to get them on the right medications and decrease the risk of having elevated heart filling pressures from heart failure. As far as invasive management goes, you can implant high output devices, or you can alter the shock vector. And so you do this by placing the lead in different parts or in different veins. And so one is placing it in the azygous vein. That was first described in 2004. You could do a coronary sinus coil. You could reposition the RV lead as it is in the heart. You could add an extra coil in the SVC, or you could have a subcutaneous array. This would be an example of a lead in the azygous vein here. And so in our patient, what we did was we decided to place an azygous coil. The azygous vein runs in a slightly different course. And so we're coming down the superior vena cava, but it runs posteriorly here. And by doing that, because the can is over here, the vector that you have for the shock is different. And it's in some cases enhanced. And so this was our patient. We had the initial single lead here, right, in the RV, but then we placed an additional lead, not in the azygous vein, to be able to get a different vector towards the can, and that was successful. Once you implant a device, you want to make sure that these patients are being followed. And so we follow them for their battery voltage. We look at the capacitor charge time. We look at all the lead parameters. What's the sensing, the pacing threshold, and the impedance for each lead? How much time is the patient needing pacing in each chamber? Are there any arrhythmias? So on device interrogation, the report will tell you what kinds of atrial arrhythmias the patient has, or ventricular arrhythmias. And then you should go through it and decipher what's going on. Have they had any therapies? Have they needed defibrillation? Have they needed ATP? You want to review one more time what parameters are programmed. And then you want to review any hemodynamic measurements. So on the newer devices, we can actually measure thoracic impedance. And rising thoracic impedance often correlates to increasing volume in the body and the chest. And so it's a corollary to heart failure. If we see somebody who's having rising thoracic impedances, even if they're not symptomatic, we might diurese them earlier to avoid them being in or having a heart failure exacerbation. I'll mention two other things before we conclude. There's a different type of ICD called the subcutaneous ICD. And this is especially attractive in young patients. It's attractive when you've had vascular complications or infective endocarditis. It's attractive when somebody only has an indication to need defibrillation but not need pacing. And so what you're looking at here is that this device is extrathoracic. It's subcutaneous, but it's outside the rib cage here. And there's a lead that runs parallel to the sternum. When is it preferred? Again, when you have poor venous access, when there's a high risk of complications from placing a transvenous system, previous device infection, or history of endocarditis, we prefer a subcutaneous ICD. When do we want to avoid it? We want to avoid it if the patient needs pacing for bradycardia. If they need pacing, the subcutaneous ICD cannot increase their heart rate at all. If they have a documented sustained monomorphic VT, but that we think will respond to ATP therapy, this is not indicated. So ATP therapy is when we pace the heart at a faster rate than the ventricular tachycardia. And so if you need that, you should not place a subcutaneous ICD. In patients who have LV dysfunction and who might need CRT in the future, subcutaneous ICD is also not indicated. This is my last slide, and I'll just make mention of this. This is a wearable Cardioverter defibrillator. This is only meant to be used on a temporary basis, so for 1 to 3 months at a time generally. And we use it in patients who've had their ICD explanted for any reason, but we still think are high risk for having a device. So until we get the new device implanted, they might wear this. Patients who, after an ischemic event, who we feel are particularly high risk, we'll have them wear this. And then for a couple of other indications, there are electrodes here that will deliver the telemetry information to the monitor. And if there's any evidence of ventricular tachycardia or ventricular fibrillation, the device will shock them. And it will also send an alert to the company that delivers this device, and they will alert us in the hospital that the patient has needed to be shocked. That concludes the talk. I know there was a lot of information, but I'd be happy to take questions.
Thank you, Dr. Ravi. It was a wonderful talk with so much details. We can have questions from the audience now. There are some physicians in the audience. They can interact. Meanwhile, you may stop the screen sharing so that people can see others.
Sure.
And I want to inform the audience that this talk was arranged by Dr. Jagdish Bhai Patel. He knows Dr. Ravi personally. Thank you, Jagdish Bhai, for this.
Yes.
Thank you.
Yeah.
Any comments, questions from the audience?
Ravi, is there an increased incidence of cardiomyopathy now?
I don't think so. I think what we're seeing
in cases of sudden cardiac death in young people, I read somewhere that there is increased incidence of cardiomyopathy in young patients.
I think what we're seeing is that we're better able to identify it. You know, because these patients are surviving, right? We're able to identify what their cause of sudden cardiac death is, and most often it will be some kind of cardiomyopathy in a young patient. So they might have myocarditis. Right now, COVID has led to COVID myocarditis. I don't necessarily think we've seen more ventricular arrhythmias because of it, but we've become much more aware of the cardiomyopathies existing in younger patients. We also have better screening technologies. So in patients who will have sudden cardiac death and are identified with Brugada, for example, or long QT syndrome, any of these channelopathies, we'll do cascade screening, or somebody with hypertrophic cardiomyopathy. And so doing cascade screening, we often find relatives who have the genotype and often sometimes the phenotype. And then they will get primary prevention devices sometimes. See, there's a question in the chat. Are there simple defibrillators that pediatricians can learn to use? External defibrillators, yes, there are. But there are a lot of companies that make external defibrillators, and each company has slightly different settings. The most important, I think, thing to understand is just ACLS, so Advanced Cardiac Life Support, and being able to interpret the rhythm that you see on the monitor. It is very different management if you see pulseless electrical activity, right? So you're seeing some electrical activity, but there's no pulse, versus if you have VT or VF, because you can actually deliver a shock at that point. Also important to know kind of the defibrillation energies that you should use. The general saying is, if you're in doubt, just go with the highest energy. And after that, you can figure out the rest.
Ravi, tell us more about your own journey. It is interesting.
Yeah. Thank you very much. Thank you. I've always been very interested in the infrastructure of healthcare and how do we move things forward, and are there creative ways that we can approach medicine. When I was in medical school, I got involved with the American Medical Association. They have a big student outreach program, and so from that, I was able to meet a few people that allowed me to work for 2 Minute Medicine, which is it's a medical news publishing company. But then we started a program called the Health Policy Fellowship Initiative, which was designed to have medical students work in health policy. In the United States, because it's not fee for service, right? Because we have so many insurance companies and there's so many third parties that control how medicine is practiced, physicians often get sidelined. And you often find that, decisions that you want to make for your patient, you cannot, or there'll be somebody else telling you that, this is not covered by the insurance, or you have different regulations that are in place that were not designed by clinicians. And one of the theories that we had is this was allowed to happen because physicians initially in the 1960s, 1970s here said, we don't want any role in politics. We don't want to have a say because it's not what we do. But as a result, everybody else started getting a say and physicians didn't. And now it's difficult to get a seat at the table. And so for about 4 years, we ran a program where we placed medical students in different medical societies across the country, and especially societies, to get them experience in health policy and politics. We had to close it down because of time commitments, but it was very effective. And then when I got to residency and fellowship, I became involved in some artificial intelligence research. And so right now, one of the research projects that I have is we're trying to simplify the language that physicians deliver to patients. Because we talk in clinical jargon, but if the patient never understands what we're saying, they won't take the medication that you prescribed. They won't call you right when they're supposed to call you. And so we wanted to start off small in discharge instructions. So the instructions that patients receive when they leave the hospital. And can we simplify that so that the layperson can understand? Doctors very infrequently have time to decrease their reading level, and so we wanted to use a computer model, an artificial intelligence model, to simplify that language. And so we won a competition here for that idea, and we received some funds to push it forward. And so we're working on that right now.
Very interesting to know. Because not only on discharge, but there are so many situations where the communication between physicians and patients is of paramount importance and often gets lost in the environment where physicians have less time to cater to large number of patients.
Yeah,
so that would be interesting.
And the thing is, what good is the best medicine if the patient doesn't take it, right?
Right.
or if they have poor follow-up, right, and they have surgical complications after,
So
what's the point?
Simplify is a company dealing with health innovations.
No, Simplify is the name of the project. If we're able to see the technology through, we will create a company from it, but that's years down the road. Still, it's just a research project right now.
Okay. Okay.
Yeah.
Good to know. Interesting. Sometime later we can have a talk on this. Contributions to these innovations in healthcare. So thank you, Dr. Ravi. It was wonderful to listen to you, and we look forward to meeting you again in this forum again. And thank you all for
Thank you so much.
attending. Thank you all for attending. We close the session here. Thank you all. Bye.
Thank you.